to UPMC SSC's talk on the menopause and fitness. I'm Fiona Roach. I'm the Business Development Manager here in the Sports Surgery Clinic. Some of you may know us. Anyone that doesn't know us, we're in Santry in Dublin. We're about 10 minutes from Dublin Airport, and we're just off the M50 and the M1. Now, we are also part of the UPMC group, who also have hospitals in Waterford, the Whitfield, in Kilkenny, Orthopaedic, and Clane in Kildare, and they have a number of sports medicine facilities across the country. And you will see a tab there for more about UPMC group if you are living in those areas and you want a bit more information. But about us, we're one of the leading orthopaedic private hospitals in the country, and we have a reputation internationally and nationally. And we look after all musculoskeletal injuries and conditions. So from your hip replacements, your knee replacements, foot, ankle, shoulder, elbow, wrist, and spinal surgery. We opened in 2007, and since then now we've expanded to 7 theatres. We've over 100 beds, 3 MRI scanners and 1 CT, and we've a separate building just up the road with a state-of-the-art rehabilitation centre. So tonight we have 3 speakers, and if you want to ask any of those speakers, you'll see a tab there for Ask a Question, so please ask your questions. Also, if anybody wants to direct anyone else to these talks, they will be live on our website by next week. So please do that, or if you want to redirect anyone to the talk. So our first speaker tonight is Miss Ruth Delaney, and Ruth is one of our shoulder surgeons here in the Sports Surgery Clinic, and she's joining us live from Italy tonight. So, and she's talking about frozen shoulder and adhesive capsulitis. And Ruth's going to join me afterwards for a live Q&A. Thank you. Thank you, Ruth.
Thank you, Fiona, and thanks to Fiona and all the team at UPMC Sports Surgery Clinic for organising the event this evening. As Fiona said, I'm a shoulder surgeon, so I'm certainly not an expert on the menopause, but there is a particular shoulder condition that we tend to see more commonly in women and often around the time of the menopause, and that's frozen shoulder. So we thought we would include that this evening. The other name for it being adhesive capsulitis, and I'll explain that a little bit. So in terms of shoulder pain around the time of the menopause, there is good evidence to show that the most common diagnosis, both premenopause and perimenopausal, by far is adhesive capsulitis or frozen shoulder. So almost a third in both cases, whether it's right before the menopause or around the time during the menopause, the diagnosis behind a shoulder pain is frozen shoulder. The second most common diagnosis was shoulder synovitis, which often goes hand in hand with frozen shoulders, inflammation of the lining of the joint. More common, that was found in the actual perimenopausal group rather than premenopausal. But the point is that shoulder pain around the time of the menopause is far more commonly due to frozen shoulder than in the general population, where there's a lifetime prevalence of frozen shoulder of about 2 to 5%. Yet in the perimenopausal and premenopausal population, you're looking at 35%, 32% of all shoulder pain is due to frozen shoulder. So what is it? We'll discuss that. Who tends to get it? What is not frozen shoulder? How do we go about figuring it out and diagnosing it? And then how do we treat frozen shoulder once we have arrived at that diagnosis? These are the things that I'll go through this evening. So the terminology that's often used medically is adhesive capsulitis. The capsule of the shoulder joint is the lining around the ball and socket. So the shoulder joint is a ball and socket, capsule around the joint, and the capsule gets inflamed, and that's the capsulitis. The adhesive part is, I suppose, reflective of the fact that there tends to be almost like adhesions or fibrous tissue where the capsule gets really tight and thick and scarred. And so that's how it's come to be known as adhesive capsulitis. We don't really know why this happens. There are some theories out there, but there's often no real cause for it. It's important when somebody has a painful and stiff shoulder that we don't just call all of those things frozen shoulder. There are other things that can present like that, and those need to be ruled out before we make a diagnosis of frozen shoulder. So one of the other things that can present with a painful stiff shoulder is arthritis of the shoulder joint. The very simple way to make that diagnosis is with an X-ray. And you'll see, as on the X-ray here in the picture, where instead of there being a nice ball and socket and some space between the ball and socket, that space on the X-ray is no longer really visible. The space reflects the cartilage. The cartilage is worn away, and there's, in that picture, what you would call bone-on-bone arthritis. Whereas in frozen shoulder, the capsule is inflamed. X-ray should look pretty normal. There are other situations where it's difficult to move the shoulder. For example, with severe weakness, it can be very difficult to raise the arm. And that can happen with a massive tear of the rotator cuff. And sometimes people will make the mistake of calling that frozen shoulder because it seems as though the patient can't move the shoulder at all. But in fact, if you take your other hand and move the arm up, or if I move the person's arm, there is movement there, they just don't have the strength. And so we're differentiating the passive from the active movement. In frozen shoulder, both will be really stiff, whereas in a case of severe weakness, the passive range of motion will often still be there. Sometimes the shoulder is just simply too painful to move. But if we again move it passively, it's possible to move through the pain, whereas with frozen shoulder, it's not actually possible to move beyond a certain limited range, or what we call a capsular end feel. The physiotherapists will often refer to that. And so basically with frozen shoulder, the shoulder must be stiff actively and passively, but have a normal X-ray. People find it quite frustrating when we can't explain why they got a frozen shoulder, what caused it, did they do anything? Usually no. And there's no real consensus on what causes it. It is inflammation of the capsule. So usually it's idiopathic for no good reason. It can happen after trauma. So sometimes you'll see somebody who falls or has some trauma to the shoulder, doesn't actually do any structural injury to the shoulder, but the shoulder responds by getting really inflamed. And that can result in a frozen shoulder. One theory is that if there's a minor injury to the shoulder, then the first response is inflammation, which is normal. The first stage of any healing is inflammation. And if the shoulder somehow gets stuck in that inflammatory phase or overdoes the inflammation, that can actually result in frozen shoulder. There are some theories about it maybe being autoimmune. And then sometimes we see it if somebody has sort of had less movement of their arm for an unrelated reason. For example, if they've been put in a sling for something else. So that's often why we don't put, say, hand and wrist injuries or elbow injuries into a sling very much, because the shoulder ends up getting stiff. Sometimes we see it after something like a pacemaker insertion, so on the left side, and maybe there's a bit of soreness there for a little while afterwards. The person doesn't move their shoulder as much, and they can develop a frozen shoulder, or after breast surgery or irradiation to that area. But there's no definitive cause known for frozen shoulder. It was interesting during COVID, we saw that there was an increase in the presentations of frozen shoulder to us at the clinic, and we wondered, were we imagining it, or was there actually a pattern to it? So we analyzed that time period compared to an equal time period beforehand, and we found, yes, there were a lot more frozen shoulders. It increased by more than a third in terms of presentations. It wasn't any different in terms of the severity or how it responded to treatment, or what proportion needed surgery. And other centers have found similar phenomenon as well. We don't have an explanation, but the theories were that perhaps it's related to a low-grade pro-inflammatory state. So either if people had subclinical or even clinical COVID, was that somehow related to frozen shoulder? Or perhaps stress. Everybody was under some mental distress at the time during the pandemic for various reasons, and that is a pro-inflammatory state, and whether that somehow translated into an increased risk of frozen shoulder is unclear, but we were able to see that there was a spike of frozen shoulder during COVID for whatever reason. So there are associations, classic associations with frozen shoulder. Diabetic is probably the most well-known one. Thyroid disorder is usually underactive, but it can be overactive thyroid as well. And the one that we're discussing tonight, around the time of the menopause. So those are all hormonal disorders. So there does seem to be some interplay between the endocrine or hormone system and frozen shoulder. It's yet to be explained fully. But the associations are not causes. They're sort of seen as patterns. Typically, frozen shoulder affects females in their 40s and 50s, but we do see men with it, and we do see people outside of those age groups. The way we go about making a diagnosis, the history can often give us a clue. So many people with frozen shoulder will have those typical associated factors that we've just mentioned, not always. And then the classic pattern is that there's been this gradual onset of pain, which is worsening over time, and it can be very, very severe pain. particularly with any sudden movements, which is a sign of capsular irritation, or having to reach or overstretch beyond the range that's available as the shoulder starts to get a bit stiff and irritable. A lot of people find things like getting dressed or undressed or reaching out to take a ticket out of the machine in a car park can be really painful. Usually the pain starts first and then the stiffness comes in a little bit later. The capsule is becoming thickened and tight as it becomes more inflamed, and that's making it physically impossible to move the shoulder, and that's why it's limited both passively and actively. In fact, if we were to put someone asleep who has frozen shoulder, so we give them a general anesthetic, muscles are completely relaxed, they're not feeling any pain, they're fully asleep, fully anesthetized, the range of motion is still the same because it's a physical block that this thickened, tight capsule is creating, physical block to movement. Typically, frozen shoulder will get better on its own if nothing is done. But the reason to think about doing anything about it is that that can take quite a long time. So it can take up to 2 to 3 years in some people. And it tends to go through these phases where it's painful and intensely painful. Then it becomes stiff and painful. The pain gradually fades away and you're just left with stiffness. And then eventually the range of motion comes back and the shoulder does tend to go back to normal. There's nothing wrong with the shoulder joint, the underlying joint itself. It's this inflammatory process involving the joint capsule that does burn itself out eventually. But because it's so miserable when people have it, it's not entirely reasonable to just wait 2 or 3 years to get better. The other ways we diagnose it then are by doing a clinical examination. And unfortunately, for whatever reason, this part is often skipped and everybody with shoulder pain is just sent for an MRI, and that's where things can get confusing. What we're looking at in the clinical exam is the shoulder being irritable with range of motion, and that obviously is non-specific. A lot of other shoulder problems can show that as well. But often we find pain towards the end range of motion. And then if it's very early in frozen shoulder, that might be the only thing that we find. If it's a little bit later, then stiffness will have developed, and the stiffness should be of both the active and the passive range of motion. All we usually need is an X-ray, and many people will already come having had an MRI. But if we examine the shoulder and there's no weakness, we can establish that the rotator cuff muscles and tendons are all working well, and we have a stiff, painful shoulder. We take an X-ray just to make sure it's not arthritic. And if the X-ray shows a normal joint, then we know it's the capsule, and that's our diagnosis. So it's a combination of history in a typical patient, the clinical exam, and an X-ray being normal. The thing about the MRIs, and we've I suppose learned this and gotten that message out there that not every back pain gets an MRI, but for some reason in Ireland, every shoulder pain still seems to get an MRI. And the reality is that nobody of the age around the time of menopause, in fact, nobody over about 30 is going to have a normal shoulder MRI. There are normal age-related changes that start to happen within the tendons, little bits of wear. They're not necessarily significant, but the radiologist has to describe everything they see. So when you get an MRI of your shoulder, you'll have a big, long report. And what we often see is that things get inappropriately emphasized in that report and people get sent down the wrong road. When the reality is that often if you MRI'd the asymptomatic shoulder, it would generate a report very, very similar. So we don't encourage getting MRIs without a good clinical exam, and often we don't need it in cases of frozen shoulder where we have a good exam. We don't need the MRI to make the diagnosis. It can be pretty uncomfortable to lie inside a scanner for 20 to 30 minutes if you have capsulitis of the shoulder. A lot of patients with frozen shoulder find that their pain is quite bad at nighttime, and it's quite uncomfortable when they lie down. Same thing inside a scanner. So the times when we will ask for an MRI is if we can't establish on clinical exam that the strength of the rotator cuff is normal, because sometimes the shoulder is so sore when you have a frozen shoulder that it's really hard to actually cooperate with the exam and do all the tests and sort of push and pull against the examiner's hand because it's just too painful. So a lot of times we'll check an MRI for that reason, but the vast majority of people we can get an exam and understand what's going on without necessarily having to put them through having a scan. Sometimes you can have a rotator cuff tear that gets secondarily stiff, and that's sort of a secondary frozen shoulder, which is a bit of a different scenario. So then if you have a frozen shoulder, what to do with it, how to treat it. So the first thing is pain management. If you're still in that painful phase, we need to decrease the pain to give back quality of life, to get back sleep, and to allow you to then do some gentle stretching of the shoulder. Because it's an inflammatory problem, we use anti-inflammatories as first line. Usually you start with the non-steroidal anti-inflammatories, simple things like ibuprofen, or maybe some of the prescription non-steroidal anti-inflammatories. It's also reasonable to do a short course of oral steroids. Yes, that's giving steroid to the whole system, but in a very short burst for maybe a week or 10 days of a decreasing dose. And many times GPs will be happy to give that, and that can give a really intense burst of anti-inflammatory treatment, which helps the frozen shoulder. Other simple things like using heat to kind of loosen it out, using ice to settle it down before you go to bed at night. Those are kind of the basic pain management strategies. We also then suggest very gentle stretching, maximum 5 out of 10 discomfort when stretching. Getting into a pool can be really helpful. People often say, well, I like to swim in the sea. Can I do it in the sea? It's not quite the same. I think you need the warm temperature of the water to help you stretch. Often people with frozen shoulder have been sent to physiotherapy and they have found that it has aggravated it, and they actually feel that physio made them worse. And I think that probably is because the instinct on the part of the physiotherapist is to try and push and get range of motion back and not let the shoulder get stiff. But when there's frozen shoulder, when there's a capsulitis, that often just actually makes it worse, and it tends to get more painful and then more inflamed and then stiffer. So usually we have people just stretch by themselves and do some self-directed stretching rather than having anybody else go at the shoulder, particularly when it's in that irritated phase. Sometimes if a shoulder is really sore, you might feel like you want to give it a rest and put it in a sling, but that's probably the worst thing to do because it will just get more and more stiff with that. So no slings for frozen shoulder. Try to gently keep it moving. With the pain management, sometimes we'll add an injection of steroids. So usually if somebody has come to me, they've probably tried some of the simple things already and will be thinking about injecting cortisone. The diagnosis needs to obviously be made first. We need to make sure the injection's going to the right place that it needs to be. And I wouldn't advise having any more than 3 steroid injections, because if you keep having indefinite amounts of steroid, it can have a negative effect on other structures in the shoulder, such as the tendons. The vast majority of cases of frozen shoulder, absolute vast majority, will resolve with anti-inflammatory treatment, injections, and gentle stretching. Most don't end up needing further treatment. We use just very, very simple stretches for frozen shoulder, which anybody can find on our website under services, and then stiff shoulder stretches. And you'll see some videos here of how to do the stretches for different directions of movement. And with frozen shoulder, again, we do advise not pushing the stretches really hard so as not to aggravate that inflamed capsule. Getting in the pool and doing some very simple things can be helpful as well, just walking in the water and some stretches, in addition to those dry land stretches. And that's what we prescribe our patients. In terms of cortisone injections, a lot of times people will come to us and may have had an injection already, but found that it didn't help a lot. And I think a lot of the time that's probably because it was in a different space than where the frozen shoulder is. So the subacromial space is the space above the rotator cuff tendons underneath the point of the shoulder. It's not actually in the main joint, but a lot of times people who are not shoulder specialists will inject there because that's kind of the easiest space to inject in the shoulder. And it is where a lot of shoulder pain comes from. So often if you go to a non-shoulder specialist and have an injection, the injection will be put into that space. That can be done from the side or from the back. So if somebody tells me they had an injection done from the side, I know that it was into the subacromial space. If it was done from the back, it could be in the main joint or it could be into this subacromial space. With frozen shoulder, the capsule and the main joint is actually what we call the glenohumeral space, the humerus being the arm bone and the glenoid being the socket. And that's where the frozen shoulder is happening. There's often some secondary inflammation in the subacromial space, or what we call bursitis. So you might find you get a bit of relief from a subacromial injection, but unless the injection's into the main glenohumeral joint, it's not treating the capsulitis directly. So a lot of times when people come, they've had an injection that hasn't helped. I'll still like to inject them myself so that I know that the location is exactly where it needs to be. It depends on the exam whether we inject both spaces or whether we only inject the glenohumeral space. And then further treatments, a small minority of patients with frozen shoulder end up having surgery. Usually that is if it's not resolving with those conservative measures, or if it's dragging on a really long time, 6-7 months. The best candidates for surgery are the ones that are no longer so painful, but may have gotten just stuck in that stiff phase. It's a small minority of people, but they find they can't really get any range of motion back. If we do any sort of surgical intervention on a shoulder that's still painful, it can take a little bit longer to settle down afterwards compared to the shoulder that's no longer so painful, but is stiff and problematic in terms of stiffness. So what we do is a keyhole surgery called an arthroscopic capsular release. So we've got that thick, inflamed, tight capsule, and we release it all the way around, front and back, using a radiofrequency wand, as you can see in the picture. It's done under general anesthesia, but we also like to have the anaesthetist do a regional nerve block. So they put long-acting local anesthetic around the nerves that come from the neck, the nerve roots, which cross over in this network called the brachial plexus. And we block that brachial plexus with local anesthetic so that when the patient wakes up after the capsular release, they don't have any feeling from the shoulder and their muscles are also asleep. So the arm is basically floppy, and that allows us to get stretching straight away. Because after surgery to release the capsule, the thing we want to avoid is the capsule scarring back in. And that's what tissue will tend to do when you operate on it or when you cut it. So unlike the non-operative treatment, if we operate, we are really aggressive with physiotherapy straight away. The nerve block will typically last 18 to 24 hours. So we keep the patient in the hospital, not because it's a big surgery, but because we want physiotherapy to start immediately and take advantage of that nerve block and actually get some stretching done passively while the arm is still asleep. The key and the challenging part is to maintain that stretching once the nerve block wears off the next day. And that's why we have people start their physiotherapy straight away after a capsular release. So this is what it looks like on the inside if we have a camera inside the shoulder, and the humerus is on the left in the picture that you see on your left. On the right-hand picture, the humerus is on the right. So the camera is looking from the front on that side. This is all the same shoulder. So we've got the camera in the back at the beginning, we're releasing the front, then we switch the camera to the front and release the back. But you can see just how thick that tissue is and how red and angry and inflamed it is. So this is one of the most painful conditions in the shoulder, and people are often frustrated because they've been told there's nothing much on their MRI, or they've been told something completely inappropriate based on an MRI, and nobody's actually put the picture together of the typical history and the exam. There are some other things you may hear about in terms of treating frozen shoulder. Hydrodilatation is something that's sometimes done. The idea is to dilate the joint capsule by injecting fluid, by injecting saline, and then a steroid injection is done at the end. It's probably the steroid injection that actually helps, though, because the capsule is so thick, as you just saw in those surgical pictures, that to actually distend it, to actually stretch it, you would need a really high volume of fluid under quite a bit of pressure. And if that's done awake, as it often is in a radiology department, there's no way you're going to be able to do that to somebody because it would be so painful. The volumes that tend to be put in are pretty small. So I think probably what's helping there is the steroid that's put in. But it's something that sometimes people will try. The other thing you may hear of is an old-fashioned technique called manipulation under anesthesia. And I would strongly advise against that. What that involves is simply putting somebody under general anesthetic and then manipulating the shoulder very forcefully to rip the capsule. And there's a few reasons why this can be problematic. It's what used to be done before we had arthroscopy and keyhole surgery. And it would work in a lot of cases, but there are some potential problems. One is that you're basically tearing the capsule instead of cutting it in a controlled fashion, so it's more likely to scar back in. But the bigger issues are that the amount of force it takes to actually rip that capsule and regain movement in the shoulder can also damage things around the shoulder, including that brachial plexus, that network of nerves going along just under the shoulder joint. I've seen patients with damage to the nerves from manipulation under anesthesia. And I've also seen patients where the humerus actually broke, so they got a fracture from being manipulated. So I would strongly advise against blind manipulation under anesthesia. If you've done a controlled capsular release, sometimes you'll stretch the shoulder gently at the end to make sure there's no last little adhesions, but that doesn't take much force, whereas the amount of force involved in blindly manipulating is quite significant. And I think in this day and age, it's probably not reasonable, as it's not very safe. So the take-home message is about frozen shoulder, which we do see more commonly around the time of the menopause, is that the underlying joint itself is normal. And even though it feels really terrible and it's hard to believe at the time when you're going through it, in most cases it will go back to normal in the end without needing any surgery. You need to have a normal x-ray, otherwise you can't call it frozen shoulder. Most of the time you don't actually have to go to the bother of an MRI. And the treatment basically is aimed at decreasing that time to recovery. The natural history is that it should recover anyway, but if we can shorten the amount of time that it's miserable, then I think that makes a big difference to people's quality of life. So pain control, gently restoring range of motion, and in a very small number of cases, maybe an arthroscopic capsular release. Thank you very much. So I think we're going to do the
yeah, I just needed to unmute myself. There's some questions. I think it's very interesting, and actually you answered a lot of the questions I think that were in my head on it. And I do know people who've had frozen shoulder who literally, you're right, after a year or two, it just goes. But those, and after 2 years, it just seems to disappear for them. So that is true. Now, someone has asked, at what point should they seek help?
I suppose, if you can stop the process early on, then you may not develop the full-blown frozen shoulder. So I think if you've shoulder pain that's keeping you awake at night, or that's making you struggle with your normal day-to-day activities, that's something that you should go and get evaluated. And so the key is, having someone examine it and decide, what the diagnosis is. And I think that's the tricky part with frozen shoulder. It gets missed or misunderstood a lot of the time.
Okay. Someone, Adele, is asking, regarding heat in the morning and ice in the evening, if this is used as an analgesic, do you suggest the ice on the skin can reduce the inflammation in the capsulitis?
I think it's, there's no hard and fast rules about it. The reason that we say it that way around is typically that the heat will kind of loosen any muscular stiffness and help people do their stretches better. The ice will tend to help with pain relief, particularly at night for sleep. How it does that, you could argue, well, it's probably not going to get as deep as the capsule to reduce the capsular inflammation directly. Is it sort of just providing a different stimulus, kind of like the gate theory of pain control, or is it actually having an anti-inflammatory effect? Hard to know, because the capsule is quite deep. There's muscle and tendon between the skin and the capsule. So the ice may not get all the way into the capsule, but I think it tends to, in a sense, just decrease the pain sensation that people are having from their shoulder.
Okay, thank you. And so, how successful is the operative capsule release in the long term? And at what stage would this invasive procedure be considered versus more non-invasive measures?
Yeah, it's very successful in the long term. Now, you could argue, well, it's frozen shoulder, it's going to get better anyway over time. Yeah. So the people who, and it's very rare, would tend to run into trouble again, tend to be the diabetics. The diabetic frozen shoulder tends to be a bit more difficult to shift. I've only very rarely seen it where they get stiff again after capsule release. I've never seen it in a non-diabetic, so a perimenopausal frozen shoulder, I've never seen not do well after frozen shoulder. You don't jump in with the surgery straight away, and you'd rather not jump in when the shoulder is still in the painful phase. So typically, most patients before considering surgery would be at least 6 or 7 months in. And if they're caught early enough and have started the anti-inflammatory therapy and had injections early enough, they may be better by 6 to 7 months. So certainly the non-invasive, the less invasive treatments are first line.
Lovely. Ruth, thanks very much for joining us tonight, for Italy, taking time out to talk. I'm now going to introduce Genevieve Ferraris. Genevieve is Associate Medical Director at the Menopause Hub, and she's going to be talking about menopause, HRT, and other treatment options. Thank you.
Good evening, everyone. I'm Genevieve. I'm from the Menopause Hub, and I'll be presenting this evening on menopause, HRT, and other treatment options. So a quick overview of what I'll be discussing this evening. We'll go through some definitions. We'll go through the symptoms of menopause and perimenopause, and then I'll be looking at HRT and HRT alternatives. So just to start with some definitions that we're all on the same page, I thought I'll start with the hormone because it's a word that gets thrown a lot. Women tend to feel like we're ruled by our hormones. It's important to know what it is. So a hormone is essentially a chemical messenger that's released from one part of the body, sends a message to another part of the body, and an effect is created. So, for example, FSH, which is follicle stimulating hormone, is released by the brain. It sends a signal to the ovary to release an egg, and ovulation happens. Now, perimenopause, menopause, postmenopause, again, words we hear a lot, and especially at the moment, we're hearing a lot of. It's helpful to know exactly what all these different terms mean. So I'll start with menopause. Menopause is essentially the end of a woman's reproductive life cycle. So it's when she stops her periods, she stops ovulating, and because she's no longer ovulating, her estrogen levels drop quite significantly. And it's really the drop in estrogen which causes symptoms of menopause. For most women, menopause happens at around 51, and the average duration of symptoms, depending on various factors, is around 7 years. Now, perimenopause is the lead up to menopause. Women tend to still be having periods at this time, but they start to become erratic. We see a lot of hormonal fluctuations, and the changes in these hormones account for symptoms. For most women, perimenopause starts at around 45. And then postmenopause is the period of time where you've then gone through your perimenopause, you've gone through your menopause, and you go into a phase where you are no longer symptomatic. So you're still not having periods, you're still low in estrogen, but you're no longer symptomatic because of the low estrogen. And then HRT or MHT, the terms are used interchangeably. So HRT is hormone replacement therapy, MHT is menopause hormone therapy. And really the mainstay of hormone replacement therapy is estrogen. As I said earlier, it's the loss of estrogen in menopause which causes symptoms. So by replacing the estrogen, that helps to improve the symptoms. And then depending on whether or not a woman still has a uterus, a progestogen is added alongside that. So what are some of the symptoms of perimenopause and menopause? I think many of us know or associate menopause with hot flashes and night sweats. And while those are definitely the kind of classic symptoms, there are over 40 different symptoms of perimenopause and menopause. I tend to break them up into physical, mental and emotional, and genitourinary symptoms. It just helps, the division makes it a bit easier to go through everything. So physical symptoms, as I mentioned earlier, those include your hot flashes and night sweats. And then around the perimenopause, we see irregular periods so that your cycle could become shorter or longer. And it's often a time when women experience heavier periods as well. It has to do with the fact that if you're not having a cycle where you've ovulated, it means that the lining of the uterus builds up over one or more cycles. And so then we start to see these really heavy periods. And that can be very bothersome for women. Around this time, we start to see a change in sleep as well. Sleep can be disturbed by night sweats, or in women who are not having night sweats, they could still have poor sleep. The kind of typical pattern that patients would describe to me is that they're exhausted, they get into bed, they fall asleep straight away, but come 2-3 o'clock in the morning, wide awake, mind is racing, they kind of can't, they toss and turn, can't go back to sleep until half an hour before the alarm goes off, and they wake up feeling exhausted. So again, fatigue, a really common symptom. It could be due to lack of sleep, but could be simply due to the changes or loss of estrogen as well. Joint aches and stiffness is a really common symptom as well, and various musculoskeletal complaints, which Ruth had mentioned earlier. Dry eyes and changes in hair, skin, and nails. We have lots of estrogen receptors all over the body, including, in places where we produce fluid, so our mucosa of our eyes, our mouth, vagina, bladder. So we often see things like dry eyes and dry mouth around this time. And then, like I said, dry skin, hair, nails, things like that. Bloating and weight gain, really common as well. The weight gain is very multifactorial. It could be due to the fact that, you are tired, you're not sleeping as well, you're achy, you're sore, you're not exercising as much, you might be reaching for different kind of comforting foods. But there are hormonal aspects as well, which make women more prone to gaining weight and kind of changing body shape at this time. We see women tend to gain weight around the middle and lose the waist. That's quite typical of changes in estrogen. Breast tenderness is more of a perimenopausal symptom, and that's to do with the fluctuating hormones. Now, not to be overlooked are the mental and emotional symptoms. These can be quite significant for a lot of women. Women who have a pre-existing history of anxiety or depression are prone to this getting worse around perimenopause and menopause, but we also know that women can experience new onset mood changes around this time as well. And that can range from anything from feeling, low, flat, or depressed, to having mood swings, especially before period, a lot of irritability, rage, anxiety, feeling overwhelmed, loss of confidence, and brain fog. This is a really common symptom and one which is very concerning for a lot of women. Because the brain has so many estrogen receptors, when we're having all these fluctuating hormone levels or the estrogen drops off, the brain needs to work a bit harder. And one of the things that we typically see around this time, around the kind of brain fog, is issues with verbal memory. So women will struggle to remember the names of people or words of things, even though they know exactly what it is, they can't get the word out. Or they might forget what people have told them. And as I said, this can be very concerning. A lot of women will come to me and say, could I have early Alzheimer's or dementia? And brain fog is not a precursor for that. It is concerning, but it's temporary. And like I said, not a risk factor for Alzheimer's or dementia. And then lastly, the genitourinary symptoms. As I mentioned earlier, because we have so many estrogen receptors along mucosa, including the vagina, vaginal dryness is a very common symptom. And this can lead to pain during intercourse as well. We see a lot of bladder issues, so urgency, frequency, incontinence and leaking, and recurrent UTIs as well, and low libido. The genitourinary symptoms are often symptoms women don't want to talk about, but it's important. They can be very bothersome and uncomfortable. And so if you're having those issues, they need to be addressed alongside the physical and emotional issues. So, this leads on to, if you're having symptoms, how do we treat them? And this is where HRT starts to come in and we start to have a conversation about it. So as I mentioned earlier, menopause is it's the end of a woman's reproductive life cycle. It's a very natural phase of a woman's life. It's not a disease to be treated, but because these symptoms for many women are really distressing and significantly impact all areas of her life, she's looking for some form of treatment. And we know that HRT is the most effective way to treat these symptoms. Now, HRT has come quite a long way. It has been kind of very good, very bad. Now we're somewhere in between. Looking at the heyday of HRT was actually first released to market in the 1940s, and that was Premarin, which is the conjugated equine estrogen. It was estrogen which came from pregnant mare's urine. That's where Premarin comes from, the name. But it was really in around the 1960s where it really picked up steam. There was a book published by a man and supported by Big Pharma, and there was a lot of messaging around the benefits of HRT in keeping women kind of young and sexy and healthy. It makes women more pleasant, and husbands were very grateful for this. And there was very much the narrative that menopause is a hormone deficiency disease and should be treated with HRT. And so between the 1960s and the 2000s, there was a massive uptake in prescriptions of HRT. Many women were on it, and it was only around the early 2000s when a study which had been going on for a few years, the results of which were published, which was called the Women's Health Initiative. The results of that study were quite alarming in that they noted a significant increase in breast cancer, clot, heart disease, stroke, things like that. There are a lot of issues with that study. We know now that the patient population that study was done on was probably not reflective of women who are actually in menopause. The type of HRT that they used and the doses were quite different, and the way that the data was interpreted and released to the public was incorrect. So there were a lot of issues with that study. But with that messaging, we started saying, don't take HRT. A lot of doctors stopped prescribing it. A lot of women stopped taking it. And so having seen this big rise in HRT use in the 1960s up until the early 2000s, we then saw a big drop off. And if women were prescribed it, they were told, you can only take it for a short time, you have to stop it at 60. And there was a lot of fear around HRT. Now going into kind of 2020 and above, there's a lot more conversation around menopause and HRT. A lot more women are understanding that, if they have symptoms, they should be offered something to treat those symptoms. We have, more data and information now about HRT, and we know that it's a lot safer than it was kind of published in the early 2000s. We have different types of HRT, different doses, a lot more kind of patient prescribing guidelines. So we feel very comfortable prescribing HRT now, but myths still exist. Women still worry about, you can only take HRT if you have severe symptoms. Only if it's really bad do you take it. If you have a family history of breast cancer, you can't take it. HRT might cause dementia, might prevent dementia. There's still a lot of conversation and a lot of uncertainties for women around HRT. And I think the role of your healthcare provider should be to reassure you around HRT and to prescribe it if you're having symptoms so that you can feel better. So as I mentioned earlier, we have a lot more safety data, more treatment options, better guidelines, better access to information. I think this is really important. Women now feel a lot more empowered to, go to their doctor armed with information and symptoms and, just have a discussion about HRT and menopause. And so we have more patient advocacy and autonomy as well. So if you have to Google what is HRT, it can be a bit of a minefield because they're all different types and subcategories of HRT. So as I mentioned earlier, HRT is hormone replacement therapy. We're giving you exogenous hormones, so external hormones to replace internal hormones and treat symptoms. HRT can be broken down into various different categories, as I've outlined here. So the first category, which I'll go through, is synthetic versus bioidentical. So bioidentical is a term which you might have heard of. It's kind of the big term in HRT at the moment. A bioidentical hormone essentially means a hormone which looks almost identical to your own natural hormones. And in theory, it's then better tolerated from a side effect perspective and possibly lower risk. A synthetic hormone is one which is made in a laboratory. It has a similar structure, but not an identical structure. Synthetic doesn't mean bad. The oral contraceptive, many of them are synthetic hormones, and women, have relied on an oral contraceptive for many years, and it's, been a great medication for a lot of women. But what we do see with synthetic versus bioidenticals are often better tolerated, but it certainly doesn't mean that they are better. It very much depends on the woman and what her aims of treatment are. In terms of bioidentical, there is a bit of an overlap in that there's also something called compounded bioidentical HRT. So this means HRT, which is made in private pharmaceutical kind of laboratories. The doses are made up according to the patient's blood results. It's not something which is endorsed by the menopause societies. They would very much recommend going with pharmaceutical grade bioidentical hormones rather than the compounded hormones. Now, oral versus transdermal, again, something which has come to market fairly recently are these transdermal hormones. That means hormones, estrogen specifically, which it gets absorbed through the skin, as opposed to oral, which is taken via the mouth. The big difference between that is oral estrogen is metabolized through the liver, whereas transdermal isn't. And when estrogen is metabolized through the liver, it kicks off some clotting factors made in the liver as well, and that can potentially increase the risk of a clot. Again, it doesn't mean that oral HRT is bad. It doesn't mean if you take it, you will get a clot. It just means that for patients who are perhaps at a higher risk of a clot, for example, if they were a smoker or they had a personal or family history of clots, we might choose transdermal as a safer alternative. And then estrogen versus estrogen plus progesterone or progestogen. This depends on whether or not a woman has a uterus. So estrogen is the hormone which we need to use to treat the symptoms. But estrogen given by itself causes the lining of the uterus to grow. And if this happens continuously over a period of time, this increases the risk of endometrial cancer. If we combine estrogen plus progesterone in a woman with a uterus, it stops that from happening. And then lastly, systemic versus local HRT. So systemic HRT is HRT given orally through the skin. It's, has an effect over the whole body. Local estrogen is given for vaginal and bladder symptoms only. So that would be a pessary or a cream, which is inserted vaginally. It's very effective at treating the genitourinary symptoms, but it will have no impact on the other physical or emotional symptoms. Local estrogen is extremely low dose. It's extremely safe, and almost all women who are in menopause and have genitourinary symptoms can take it. So it's all well and good knowing what HRT is, but it's also important to know who can take it. So HRT is indicated for the treatment of symptomatic women in perimenopause and menopause. So if you were having symptoms that are bothering you, a lot of people say to me, well, how many symptoms should I be having? How bad should the symptoms be? Really, it depends on you. Every woman is different. Every woman will experience her menopause differently. You might have 1 or 2 symptoms and those are a big issue for you. You might have 10 and they're not a big issue for you. But if you are having symptoms which are impacting you in any way, those symptoms could be treated with HRT. We also know that HRT should be prescribed for women who go into early menopause or who have premature ovarian insufficiency. Early menopause is defined as going into menopause before the age of 45, and premature ovarian insufficiency is before the age of 40. These patients are at a higher risk of developing osteoporosis and cardiovascular disease as a result of the estrogen deficiency. And so in these women, we offer HRT to replace the hormones they would have naturally had up until the age of natural menopause, which is around 51. Surgical menopause is when a woman's ovaries are removed. This might be part of an as part of a hysterectomy, or it might be done as a separate procedure, an oophorectomy for things like in women who are high risk of getting ovarian cancer. Again, if this happens in women who are below the age of menopause, we want to replace the estrogen that those ovaries would have been producing to prevent the risk of osteoporosis. And then it can actually be considered as treatment for osteoporosis in symptomatic women, so women symptomatic of menopause under the age of 60. The big kind of no's for HRT. So who can't get HRT? This is women who've had a personal history of breast cancer and some types of ovarian cancer. Look, this is a bit nuanced. We do have patients who have had breast cancer before and they're having a lot of symptoms. They come and see us and we have a discussion around it, but it's very much weighing up risks versus benefit. And, when we're looking at this category, the yes category, we know that the benefits significantly outweigh the risks. And so it's very safe for these women to take. In this category, the benefits likely are outweighed by a significant risk. For a woman with personal history of breast cancer, there's a much higher increased risk of recurrence of breast cancer if she goes on HRT. The maybe category this is where we need to decide what is the benefit, what is the risk, and does that benefit outweigh the risk, and can we use HRT? So these categories include women who are over 60 or more than 10 years after their last menstrual period, if they've had a previous clot, if they've had a previous stroke or heart attack, and if there is a significant family history of breast cancer. Again, it's not to say that these women can't get HRT. It's very much a decision which needs to be made between the patient and her doctor and looking at all the various factors. So the main benefits of HRT is symptom relief. That's the primary reason to use it, and it's the best thing that it will do is that it will improve your symptoms. And the symptoms are really what we went through earlier. So in terms of your mood symptoms, the vasomotor symptoms, the genitourinary symptoms, those will improve with HRT, musculoskeletal, and sexual functions. We know we've got good evidence. If you take HRT and you're in menopause, those symptoms will be improved. As I mentioned earlier, it should also be considered first line for prevention and treatment of osteoporosis. That would be in our kind of younger patients who go into an early menopause or who've been diagnosed with osteoporosis. They talk about a critical window of HRT, and this is really about when should we be using HRT to ensure that there's benefit from a kind of cardiovascular perspective, because we do have good evidence HRT reduces the risk of cardiovascular disease, but it must be started within that critical window, which seems to be within 10 years of the last menstrual period or before the age of 60. On my slide earlier about the kind of changes in HRT and the views to it, there was something about dementia. There appears to be a risk in a reduction in dementia risk when we use HRT, but we need more evidence, and it's certainly not a reason to be prescribing HRT. We shouldn't be using it, giving it to asymptomatic women to reduce the risk of dementia, because we don't have good enough evidence to say that. And then, as I mentioned earlier, benefits for early menopause and premature ovarian insufficiency. Now, what are the potential side effects and risks? Because really it's these risks which have been overstated over the years, and that's what many women are afraid of. The side effects are, the most common ones would be breast tenderness, irregular bleeding, some fluid retention, certainly not weight gain, but fluid retention, headaches, and GIT symptoms. These are often temporary, and they can be alleviated by changing the type of HRT that we use. Now, the big kind of risks around HRT would be the increased risk of breast cancer, and then potentially endometrial cancer, clot, and stroke. Now, the endometrial cancer risk comes into play if we're not using progesterone alongside estrogen or enough progesterone alongside estrogen. But if you're on a regimen, if you have a uterus and you're on estrogen plus progesterone, that risk is very insignificant. And the clot and stroke risk, again, depends on the type of HRT that we use. If we're using transdermal, it's very low. The breast cancer risk overall is very low as well. This is a graphic from the British Menopause Society, and it shows that for 23 per 1,000 cases of breast cancer diagnosed in the UK, an additional 4 cases occur in women who are on HRT. So yes, there is a risk, but it's not significant, and certainly not as dramatic as what was stated in the past. However, for some women, this risk might be unacceptable, and she may decide she doesn't want to take HRT. So in that case, for women who either can't take HRT, they're in that no category of the slide I showed earlier, or they don't want to take HRT, they might still have symptoms, though, that they want to treat and that are bothersome. And so that's when we need to look at non-hormonal therapies. And sometimes I'll say this to patients and they say, oh, but, I don't want to go on supplements. I want medication. And, I want to make it clear that there are medical treatments available that are not hormonal, but that can still very effectively treat your symptoms. So the first class of medication would be antidepressant medications. These are your SSRIs and your SNRIs. We're certainly not using these medications for women who are depressed in their menopause. We're using it because it treats the symptoms of menopause like hot flashes and night sweats. It's very effective at treating vasomotor symptoms. It can obviously have a positive mood benefit. It may help with sleep. And we typically use much lower doses in menopause for menopausal symptoms compared to the doses which are used in clinical depression. Clonidine and oxybutynin are medications which can help with hot flashes and night sweats. They don't have kind of other benefits, and they tend to have side effects that are quite unpleasant, including dry mouth and headaches. So a lot of patients will stop taking them. They find it quite difficult medication to take. Gabapentin is an interesting medication in that it's an anti-epileptic. It's also used for chronic pain. It can be used as a mood stabilizer, and again has good benefit for alleviating hot flashes and night sweats. It can have a sedative effect, so good for sleep, may help with mood as well. And then Veoza is a brand new medication which has just been released. It's a really exciting development because it's the first medication which has been designed specifically to treat hot flashes and night sweats. So these other medications have other indications, and they used, they also have a benefit of treating hot flashes and night sweats, whereas Veoza is designed to work in the brain. It stops hot flashes and night sweats from originating, and it's a great option for women who are not able to take HRT. Under medical therapies, I've put psychotherapy and CBT as well. CBT is cognitive behavioral therapy. We have really good evidence for this in terms of helping with hot flashes and night sweats, and help with mood and sleep as well. CBT is a specific form of psychotherapy, kind of helping with reframing thoughts around events, and a lot of women find it very useful, either by itself or in addition to these other medications. And then looking at the non-medical alternatives, these are things that probably all women should be doing anyway to support their health during this time. But for women who, didn't want to take HRT, or they felt that their symptoms were mild and they wanted to manage it from a lifestyle perspective, these are things that we should be looking at. I must say, a lot of women struggle to implement these changes when they're not feeling great. Sleep hygiene is very important. When your sleep is being constantly disrupted because of night sweats, it's quite difficult to make those changes. But sleep hygiene is really around things that we all know we should be doing. Don't be on your phone late at night, going to bed at around the same time, don't drink coffee too late in the day, just optimizing things to make sure that you have a better sleep quality. Weight management and diet, it is important to maintain a healthy BMI during this time. Women's risk of cardiovascular disease increases when she goes into menopause, and so we want to try and reduce that by managing kind of lifestyle factors as well. The best kind of diet is probably a Mediterranean type diet. So that's lots of brightly colored fruits and veggies, lean protein, healthy whole grain carbohydrates, good fats, and a reduction in really processed and refined carbohydrates and sugars. And then stress management, this is something which is much easier said than done. They talk about, doing things like yoga, meditation, breathing exercises, all things to help reduce stress in the moment. Like I said, easier said than done. Supplements is a big one. If you go into any health food store and you ask for something to take for menopause, there are almost hundreds of options available. A lot of them at best won't work, or at worst could have some harmful side effects. So, I'd be cautious of the wide range of supplements that are available. I always recommend my patients take vitamin D, especially during the winter. We just don't get enough sunshine, unfortunately. And omega-3s are quite helpful as well if you're not getting kind of 2 portions of fatty fish a week. Otherwise, you don't need to be buying hundreds of expensive supplements. Acupuncture, a lot of women will anecdotally report that it helps their symptoms. It's unlikely to do harm. So, if this is something that made you feel better, there's no issue with using it. Although the actual data in terms of efficacy is quite sparse. Cold exposure, this is, when I moved to Ireland, I'm from South Africa. When I moved to Ireland, I was quite amazed at how many people were swimming in the freezing cold sea. And I noticed there was a lot of women as well. Interesting, they've recently released a study in the UK which showed that women who regularly sea swam had a reduction in menopausal symptoms, or perceived reduction. So there's definitely something to it. I think it's a big social thing as well, which is, really important as well from a lifestyle perspective. But again, as long as you're dressing warmly afterwards, you've got your tea and your dry robe, it's probably unlikely to do harm. It could be a nice thing to add in. So in summary, menopause is not a disease. It's a natural phase of life. But if these symptoms, or if this phase is accompanied by bothersome symptoms, they should be treated. HRT is the most effective treatment, and while HRT has been thought of as very good and then very bad, kind of somewhere in the middle now. And we know that it's a safe, effective option to be used, although it certainly shouldn't be used solely for the prevention of disease. And there are good alternatives available for women who can't or choose not to take HRT. Thank you.
Genevieve, thanks very much. It was a really interesting talk. And again, you answered, I think, a lot of people's questions in that. But we have a few questions that have come in. First from Paula, can HRT be used to treat high cholesterol, which manifested post-menopause, or is it just better to take the statins?
So cholesterol levels can definitely increase postmenopausally, but statins are still the preferred way to treat them. HRT is not indicated to treat high cholesterol.
Okay, lovely, thank you. How long can you stay on HRT for? And what happens if you do stop? Do you then go through the menopause again? Is it possible to stay on HRT into your 70s?
So in theory, you can be on HRT for the rest of your life.
Okay.
You know, previously there was a kind of this cutoff. You can only be on it for 5 years or up to the age of 60, and that's changed. Women can be on it for as long as they're getting benefit from the HRT and there are no side effects or major health issues that arise. If you come off of HRT, you're not going to go into menopause again. So really the principle of HRT is to treat the symptoms during menopause, but once you go into post-menopause and those symptoms significantly reduce, at that point we could take you off of HRT and your symptoms shouldn't come back because you're now in post-menopause.
Okay, thank you. At what point should I consider starting HRT?
Patient dependent, really around symptoms. So if you are getting symptoms in your mid-40s and they're bothersome, consider it. If you're only starting to get symptoms in your early 50s, you know, consider it. But it's really around, rather than age, go by symptoms and how bothersome those symptoms are for you.
Okay. And what are the potential effects of menopause on reproductive health, and are contraception options still available?
So your fertility declines as you go through perimenopause because ovulation, your egg numbers reduce, ovulation becomes sporadic. There's about, pregnancy is not impossible in perimenopause. It's about a 1% chance of falling pregnant. And then menopause can't fall pregnant. They say that you should still consider using contraception up until 1 year post your last period. So contraception is still advised. And the best options would be condoms, the progesterone-only pill, which can be used up until age 55, the Mirena coil, or a vasectomy if your partner is open to that. Okay,
thank you. And what's the role of a pelvic floor physiotherapist when it comes to menopause?
So that's really important. You know, as I mentioned in the symptoms, there are a lot of genitourinary symptoms that occur during perimenopause and menopause, and a lot of changes in the vagina, the vulva, the bladder, the pelvic floor, and women might start to experience bladder issues, but also kind of bowel issues as well, including things like fecal incontinence. So any bladder issues that are bothersome around that time, a pelvic floor therapist can be incredibly helpful and help you to know which kind of muscles to engage, which ones to relax, and how to manage those symptoms rather than just relying on medication.
Okay. Genevieve, thank you so much for joining us tonight. And I'm going to introduce now our next speaker, which is Dr. Colm McCarthy. And Colm's looking at sports, menopause, muscles, maintaining fitness. And Colm's one of our sports medicine physicians here, and he will join us live for a Q&A as well. Thank you.
Hello, thank you very much for inviting me to speak this evening. My name is Colm McCarthy, and I'm a sports and exercise medicine consultant working at the UPMC Sports Surgery Clinic in Santry. And I'd like to talk about menopause and muscles and bones and tendons, and about maintaining fitness during menopause. A bit about my own background. My training was both here in Ireland and then subsequently in Australia. In Australia, I was lucky enough to work with some really amazing female athletes across rugby union, netball, the AFLW, and in ballet. And there's been some very exciting advances in the last few years in the field of female athlete health, especially in relation to menstrual health, bone health, injury prevention, and strength. And so a lot of that's transferable to the general population as well. I came back to Ireland a year ago, and I'm now working in the Sports Surgery Clinic in Santry, and see there a mix of both kind of elite sports and then regular people like us just enjoying movement and activity. So menopause, it's pretty, I suppose, a kind of a broad word, broad term, fitness and menopause. I guess we could talk about perimenopause, which, you know, around the age maybe 45 to 55, or we could, you know, define menopause as being post-menopausal, which is the time after the last period. So really, I suppose exercise or fitness in menopause, we're talking about quite a big chunk of a woman's life. You know, if the average life expectancy is 84, menopause is going to be at about a third of your life, I suppose. I suppose how you want those years to look is everyone's own choice, and everybody's got their own goals. But no matter what our plans are, whether you want to lift trophies or grandchildren or cabin bags and cases, the same principles apply in terms of our physical capabilities, and that's really that you've got to use it or lose it. So I suppose if we're talking about, you know, kind of perimenopausal age, you know, kind of age 45 to 55 could be defined as midlife. Whenever I hear the word midlife, the word crisis kind of comes to mind. But really, I think it's an opportunity at this stage of our lives when you kind of look at the choices you make now, and especially with regards to activity, how that's going to influence your health and your ability to do the things you want on into the future. So if you're pressed for time, I'm going to give you the short version of my talk now, which is one slide. Basically, getting active or staying active if you're already active through the perimenopause and menopause is likely to help you live longer, healthier, and more independent. It's going to reduce your risk of most of the main health hazards. It can help with some perimenopausal symptoms. It has been proven to improve mood. You'll likely enjoy it. The recommendations from most of the main kind of health bodies are to do a mix of aerobic and resistance work, and get some impact into, pick something enjoyable, keep it up. And then in regards to menopausal hormonal therapy, there's possible some benefits to that in terms of muscle and bone health. So that's the short version. If you need to go home now, you can. Otherwise, we'll have a bit of a chat about those things in more detail. So I'll start off just about talking about exercise in general, and the concept of exercise, which is really kind of a new thing in terms of the long history of human evolution. Talk about some of the big wins, some of the really compelling reasons to stay active. Talk a little bit about exercise and perimenopausal symptoms. Then I want to introduce the terms sarcopenia and osteoporosis, if you haven't already heard of them, and why these are two really important things to work against in the menopausal period. And then also talk a little bit about some of the common musculoskeletal issues or injuries that I'd see in my practice that are more common in menopausal women. And then finally, we'll touch on HRT or MHT and the effect it can have on our musculoskeletal system. So first of all, yeah, just defining what's exercise, what's physical activity. Sometimes the two are used interchangeably, but physical activity is any activity you do in daily life. And that could be, you know, gardening, housework, playing with kids. Whereas exercise is a planned physical activity that keeps you fit or makes you fitter. And really, this is quite a new thing in the last couple of generations, because for the majority of human history, we had to be physically active just to feed and house ourselves and just get through the tasks of daily living. So the idea of actually going for a run or buying some weights and lifting them for the majority of human history would have been a pretty crazy thing to do, because life was hard enough already. However, that being said, from that kind of evolutionary perspective, exercise has always been a part of life and right through into older age. So in kind of non-industrialized societies, both men and women would have been active really right through their lives. There's an interesting hypothesis as to why humans are able to keep up a good level of physical activity right into old age. It's called a grandparent hypothesis, and it's basically that societies that flourish rely on the older members of society to be active and healthy and able to help out with physical work involved in keeping the community going. So we are genetically programmed to be able to keep fit and active and strong right into later life. So I'm going to talk here about a few really compelling reasons to keep active and to keep exercising right through the perimenopausal period into menopause and right through life. Exercise has been proven in really strong, quite strong epidemiological studies to reduce the risk of getting 7 of the really most common cancers, including breast and colon and endometrial cancer. And this is in the realm of about a 20% reduction if you compare people who are physically active with people who aren't. There is a pretty big change in terms of a woman's cardiovascular risk, and that's the risk of heart disease, comparing before menopause and after. Estrogen has quite a protective effect on the heart, and so in the absence of estrogen then, for a number of reasons, the risk of getting cardiovascular disease goes up by a factor of about 2.6 between premenopause and postmenopause. And on the left there, they're the main contributors to this, such as worsening insulin resistance, higher blood pressure, higher cholesterol, and reduced sleep quality and mood changes can also have an effect. The good news is that exercise can improve literally every single one of those risk factors. Exercise is also likely to improve your mental health. Again, there's pretty strong evidence from studies that follow women through menopause. And there was one interesting study, the SWAN study, over 20 years in the United States, and they followed a group of women for 20 years through menopause. And there was pretty clear evidence that those who were physically active reported better mental health and better quality of life, reduced symptoms of depression, anxiety, and stress, and generally felt better mood and more vigor and well-being. Another thing that I suppose would be pretty topical at the minute is whether exercise can actually improve some of the symptoms of the perimenopause transition. I suppose the classic one is hot flushes or hot flashes, but as you know, there are many other symptoms and other things associated with the perimenopausal period which can negatively impact on a woman's health and well-being. And there's been some research into how exercise can potentially help some of these. One of the most interesting ones, I guess, from my perspective as a sports and exercise medicine doctor, is musculoskeletal pain in menopause. It's been shown in studies to be one of the most common menopausal symptoms, so pain or aches in muscles and joints. About, again, 1.6 times the amount of aches and pains to premenopausal, which is a pretty big increase. There's also been some good evidence from these studies that in people who are active and take regular exercise, they reported less headaches, less joint pain, less heart palpitations. And so I guess we have some evidence there that some of the major symptoms of the perimenopause or the menopause transition, such as difficulty sleeping, mood changes, low energy, palpitations, headaches, and joint muscle aches, can be positively affected by exercise. The jury is still out really on hot flushes, whether exercise has a significant effect on this. There is a theory that because we know that exercise increases your what's called parasympathetic tone, so the kind of after you exercise, your kind of rest and digest, relax system is upregulated, and so this has been kind of postulated to potentially help with hot flushes, but we don't have very strong evidence on that. There is good evidence from studies that keeping physically active will also help with keeping a favorable body composition. When I say favorable body composition, I'm not talking about a definition of beauty, but of health in terms of maintaining your muscle mass and reducing the amount of what's called central adiposity or visceral fat, which means the weight you carry around your middle, which we know increases after menopause. So maintaining good activity and exercise can help offset this, and that has health benefits because we know that carrying weight around the middle has effects on cardiovascular health, insulin resistance, etc. So they're all good reasons if you didn't already need them to keep active. Just want to talk a little about I guess the main musculoskeletal effects that we see in menopause. Menopause, I guess the decline of estrogen. Estrogen it's not just a reproductive hormone, it has effects on lots of body systems, and it has a really strong effect on both our muscular system and on our bones. And so this can have big knock-on effects for a woman's health. Estrogen helps to maintain muscle mass. It helps with the muscle's response to exercise, and it also helps with making new muscle fibers. So sarcopenia there's an increased risk of that in menopause, but really that comes about when you combine inactivity with a lack of estrogen. Osteoporosis then is where you get a decrease in bone density, and the risk of that is an increased risk of fractures, which certainly later in life can have a really devastating effect on a person's independence. This kind of drawing on the top is what's meant by sarcopenia. So where you have muscle in the dark red. Over the years, if you have a lack of estrogen and also a lack of exercise, the combined effect is that the muscle gets smaller and the fat mass gets bigger. I don't expect anyone to look deep into this complicated diagram, but this is to do with bone turnover. And the bottom line is that in the absence of estrogen, bone breakdown starts to exceed bone formation, or bones get thinner. And the other thing that does the same thing is a lack of mechanical stress. And again, we'll talk about that in a minute about why impact exercise is so important to maintain bone health. I was talking about sarcopenia and the loss of muscle, and why that's something that you definitely want to avoid. And that's not just because of muscle's role in moving the body. Muscles are a really amazing piece of our bodies that do so much more than just move us. Muscles can send messages to other parts of the body, so it's kind of like it's an endocrine organ. Substances released from muscle, which are called myokines, can have effects on the brain, the gut, the kidney, the pancreas, the liver, fat cells, our immune system, our bones. And so when you have muscle and maintain muscle, it sends all these positive messages out to the rest of your body, which decrease inflammation, increase your immunity, and this is where the decrease in cancer risk comes from. Helps you metabolize your food better, makes you happier, makes your bones stronger. So muscle is really such an important organ in the body, rather than just being something that moves us. So that sort of paints a grim picture. Is menopause a one-way ticket to sarcopenia and osteoporosis? And the answer is definitely no, because it's possible to maintain your muscle mass and function and to keep your bones strong with the magic pill. And that magic pill is exercise. Exercise, a combination of both aerobic and resistance exercise. In other words, getting out of breath and lifting heavy things will keep your muscle, both in terms of the muscle mass and the muscle function. In terms of osteoporosis, again, it's not an inevitable one-way ticket to osteoporosis. By either maintaining if you're currently doing impact activity or taking up impact activity now, that loading effect on the bone will maintain bone density and potentially even improve it. Impact is basically like jumping, landing, so things like running, and it actually doesn't take a lot to get a good stimulus to the bone. They reckon that 50 jumps a day is enough to maintain your bone health, and that's something that all of us can do, and right up into the elderly, with the right advice and modifying what sort of impact they do. So that's the kind of the how and the why. In terms of what exercise to do, there's plenty of kind of science-backed recommendations on what's the best mix to do. Very interestingly, as an aside, I came across this in the paper, where in Germany, in certain states of Germany, it's been mandated that people who own dogs need to walk them at least twice a day for half an hour each time. So an hour of exercise for dogs, because to not do so would be cruel. And I guess inside every dog, every Chihuahua or Labrador is an ancestral wolf, that was, you know, evolved to roam around in packs. And the same is true for us, inside all of us working in an office or wherever. You know, there's a human that was designed for walking long distances to dig for food or to climb trees or carry wood. And if we neglect that, we don't feel good either. So there's a few different bodies, such as the WHO and the ACSSM and lots of different organizations, health organizations that come up with recommendations. They're all pretty similar. So this is for adults in general. This is not for specifically for women in perimenopause or menopause. Same advice will be true for a man or any healthy adult. But there's extra importance, I guess, at the bone loading part of this for menopausal women. So the advice is to do 3 to 5 days a week of moderate to vigorous aerobic exercise, 30 to 60 minutes per time, to make sure that some of those sessions are bone loading or impact type work. And then a really strong recommendation is to do 2 days a week of resistance or strength training. I guess this is maybe the little thought kind of paradigm change in how you might look at the exercise that's going to benefit you. Whereas maybe, you know, it's easy to get out for a walk, maybe takes, excuse me, a little more planning to get the resistance or strength training in. But we'll talk a bit about how that might be done. It's also worth doing some flexibility and balance work. So first of all, I just about moderate aerobic exercise. You know, just what exactly does that mean? So moderate exercise is exercise that feels somewhat hard. The best way of thinking about it, I find for myself, is that it's exercise where you could talk, but you couldn't sing a song. So something like brisk walking, where you're a little out of breath, you know, you couldn't sing, but you can maintain a conversation. Swimming, jogging, cycling, also things like team sports or racket sports can all be considered moderate aerobic exercise. There's a couple of formulas for heart rate as well, but they're a little trickier. I think talk, not sing is great. If you have a Garmin watch, it'll also tell you when you're in that kind of moderate aerobic exercise or zone 2. What is bone loading or impact then? So if we look at these are all good forms of aerobic exercise, but not all of them are bone loading. And walking really doesn't give enough impact to generate bone loading. Swimming doesn't generate bone loading, and cycling really doesn't, a little bit through the muscular activity, but really doesn't much. You need something where you're kind of jumping or moving or hitting the ground a little harder. So things like tennis would definitely be really excellent bone loading activity. It's multi-directional, you're running forward and back. All those things give what I call novel stresses, so changing messages to the bones, and that's what really stimulates them to get strong. Dance is a really good form of impact exercise. Picture on the left is Zumba, which has been shown to be really good in terms of bone loading because of the jumping and the sideways movements. Team sports are great. Picture there is Gaelic football, but I mean any team sport where you're changing directions. And the other benefit of those is that they can be really fun and social. And as I mentioned, just simply jumping, so jumping off a box, hitting the ground, that's impact. Needs to be a little thought around the safety of that for an older person or someone with osteoporosis, but they can all be modified. So yeah, getting in 2 to 3 times a week, some impact loading, so not just walking, cycling or swimming. Resistance exercise then, so strength or resistance training, that's basically where you're making your muscles work hard and get tired. So again, there's lots of different ways to do this. Certainly gyms, gym classes, anything with lifting weights is good. Things like Pilates are also a form of resistance exercise. Your body weight is a form of resistance. Things that work the big muscle groups like your glutes and your quads, so things like squats, lunges are really excellent. And again, lots of different ways to achieve the 2 days of strength work. It could be through something like a class or going to the gym, or it could be in your own living room with some weights. And there's some pretty good like YouTube workouts, things like that. If you're looking for inspiration, obviously going to see a professional to develop a program for you would be optimal. And there's some good online things and some good apps as well. But big benefits to be gotten from doing resistance training twice a week in terms of strength, function, and maintaining that muscle mass that I was talking about earlier. That's so important for your overall health. But really the best exercise is the one that you enjoy and that you'll keep doing. So I think if you can find something you enjoy, that's always going to be the best. Menopause and tendons is really quite complex. I'm not going to go too much into it. We're kind of a bit unsure how the decline in estrogen affects tendons. It reduces collagen formation, increases the stiffness. But again, if you keep your tendons strong through exercise, that's the best way of keeping them strong and avoiding injury. Quick word on MHT, menopausal or hormonal therapy. So in terms of taking HRT or MHT, that's going to replace the estrogen that you would otherwise be losing through menopause. And it's been shown pretty clearly to help maintain muscle mass and function. And it also has a positive effect on bone, again, because you're not losing that estrogen effect on maintaining bone mass. Again, this coupled with exercise is going to give the best results in terms of maintaining muscle and bone mass. If there's any kind of masters athletes or people who like to compete as well as just keep fit, there's a few studies which show that MHT or HRT can help with performance, more so in terms of the adaptation to training. It's not like it makes you run faster on the day you take it. It's more in terms of being able to maintain muscle mass. And there's also a bit of evidence around recovery from exercise sessions. So yeah, possibly something we're thinking about. It's in masters athletes, but that's not saying that I'd be necessarily promoting it to people to keep on winning races, but there is some science there. Again, in terms of training and the effect of estrogen on muscles and bones, that's pretty clear that is a positive influence. It's a little less clear about the influence of estrogen supplementation or estrogen replacement on tendons. So the best advice is to make sure that through good strength training that you maintain your tendons in good condition. The final thing I'd like to talk about are just some of the common conditions that I'd see in my job as a sports and exercise medicine physician in postmenopausal and perimenopausal women. I'm just going to talk about 2 conditions. First of which is knee osteoarthritis. This is really common in the general population, and it's twice as common in women as it is in men. The advice for managing knee osteoarthritis is really pretty clear from all the major medical bodies that deal with it, both the medical, rheumatological, surgical one. And this little graph here is good, I think, from the Osteoarthritis Research Society International, and that's that everybody who has knee arthritis should receive education about activity, exercise, and weight management, because this is what makes the biggest impact on knee osteoarthritis. So maintaining a healthy weight as best as possible, keeping good strength in the muscles around the knee, and keeping the knee moving. Exercise is good for knee osteoarthritis. In the old days, people might have thought rest was the answer, but that's been shown to actually make things deteriorate because of some of the metabolic effects, the negative metabolic effects that being inactive have. So again, exercise therapy is really the mainstay of managing osteoarthritis. Some people may benefit from medications or injections, and a very few need surgery. But in our clinic, we manage the vast majority of people with exercise, and it works really well. Another common and really annoying and painful issue is gluteal tendinopathy. This is a pain at the side of the hip. It's mainly the gluteus medius and minimus tendons, which come down at the side of the hip and attach onto the bony part of the outside of the hip called the greater trochanter. And that's the bit that sort of sticks out when you lie down, and so it can often be quite uncomfortable to lie on. And it can be really debilitating, stopping people from running or walking even. So that's something we'd see a good bit of. Again, the management for that, there's been some really good research into it, and exercise and specific exercise and strength, along with some simple advice on certain postures to avoid, can quite effective in treating this. Doesn't mean that it's a quick fix. It takes a while, but it's been shown that exercise and education beats injections for improving gluteal tendinopathy. So that's something we'd see a bit of, some of the really tricky cases of that. Again, sometimes we use some injections or things like shockwave therapy, but by and large, good strength work is the way to both prevent and treat gluteal tendinopathy. And then just a final word on gluteal tendinopathy and menopausal hormonal therapy, or HRT. Read a bit about this in just around the place lately, and a few of my patients have mentioned it to me as to whether HRT might help their gluteal tendinopathy. And there's really only been one study on it, so not a lot of evidence, but that did show their combination of menopausal hormonal therapy in the form of topical estrogen combined with an exercise program was better than an exercise program alone. So only one study, but potentially promising. Certainly very interesting. So finally, just I've gone on about how great exercise is and how it's the solution to all problems. Obviously, exercise can bring its own problems in terms of picking up injuries and that. So simple advice to try and minimize that risk. So festina lente, it's Latin for make haste slowly. And I think that's the single best piece of advice. Whatever you're doing, if you're starting from a low base, just build up slowly. If you're already doing a lot, don't add a lot suddenly. Just build slowly and let your body adapt to it. Before you do impact work like running, make sure that your muscles are strong. Make sure you get good recovery. It takes a little longer to recover as you get past the age of 40. That goes for men and women. So a day off in between hard sessions. Make sure you eat well, and then get some expert advice if you're embarking on a training program. And then finally, if all that doesn't work, just get the car. Thank you very much. Really appreciate the opportunity to chat to you. Hope you got something out of it, and I am more than happy to take questions if you have any. Thanks a lot.
Colm, thanks. That was a really great talk. A lot of information as well. So two questions here to start with. Lady Margaret, she has full range of movement. She has a lot of pain though in her shoulders, mainly at night time. And she has had it looks like she's had one steroid injection, and she's asking about bursitis. I suppose like frozen shoulder, does it burn itself out and eventually go away, or is it different to the frozen shoulder?
Okay. Yeah, it's a few things to consider in that question. So yeah, first off, does bursitis burn itself out? So look, it doesn't burn itself out in the same way that frozen shoulder does. Like Ruth would have been talking about how over a long time, like maybe 2 years, eventually frozen shoulder burns out. Bursitis doesn't kind of predictably do that in the same way. So something, I guess, has to change to relieve that bursitis, whether that's better movement patterns in the shoulder, or treating the inflammation that goes with the bursitis. The other thing to say, so with nighttime pain, and that's often that kind of an inflammatory thing. So it's when things are sore at night, something's inflamed. The other thing to think there is, although there might be bursitis on the MRI, it's not necessarily bursitis causing pain. Lots of people, when you do an MRI, will have fluid in the bursa. It'll be described as bursitis in the MRI report, but that might not be the cause of pain. It could be from the rotator cuff tendons, could be the source of pain. The AC joint, which is the acromioclavicular joint, that could be the source of pain. You could even have pain coming from elsewhere, like from the neck. So I guess if I think you said that the person in question had a steroid injection, and if that hasn't worked, might be just looking and rethinking the diagnosis, just having a look at everything again to see, might it be something else. And sometimes if it really does look like bursitis, a second injection can help, and especially under ultrasound, so it can be really targeted because the bursa is pretty small, relatively speaking. So an ultrasound can help to target an injection to the bursa. The first thing to do is just revisit it that definitely the bursitis is causing the pain. But it doesn't burn itself out in the same way frozen shoulder does.
I know. Okay, thank you. So there's pain on the outside of their hip, which sounds like the gluteal tendinopathy you were talking about in your talk. Muscles very tight. Should they stretch more? And if they stretch more, will it help?
So if it is gluteal tendinopathy, pain at the outside of the hip. So if this person has pain at the outside of the hip, there's a pretty high likelihood it is gluteal tendinopathy. Often the muscles, so the tendons are the bit that are sore, but the muscles that are attached to the tendons are, in the side of the hips, and they can feel really tight and sore as well. So you can get pain up into the kind of buttock area or the sort of side of the buttock. And it kind of feels like you should stretch it, but it actually probably doesn't help, and it might be detrimental because what you're doing is pulling the tendon across the outside of the hip with the sort of stretches you do, like say, like a pigeon stretch, or bringing the leg across your body to stretch the hip, stretch the buttock muscles on the outside of the hip. That can actually stretch the tendon across the bony part on the outside of the hip and actually aggravate things more. So it feels pretty good for a few minutes because you feel a bit looser, but actually it can aggravate things. So gluteal tendinopathy is something where stretching is actually not recommended and probably best avoided, and better to work on the strength.
Okay, lovely. Thanks, Colm. Colm, thanks very much for joining us tonight. And all these talks will be up on our website by next week if anybody wants to go back to them or redirect someone to see them. And we will be sending an evaluation form out for you to fill in, and which is always helpful for us to learn what you'd like to hear about in the future as well, and what we could do better. So thanks again for joining us tonight, and we'll see you at the next talk. Thank you.